So thank you very much indeed, Ed, for the introduction, and thanks, Chris, for that fantastic opening to our event today. And I think that should inspire us that we may be on the right track. What I really wanted to do was just talk briefly about some of the strategic thinking and planning behind the launch of the Institute. We've been engaging with the nearly 200 students that are enrolled on our master's and bachelor's level global health training and education programs. It's been a fascinating experience, and part of that is what is global health for them and what would they like to see the Institute doing. I'd like to give a huge thanks to Katya, Selma, Sean, Kate, Miriam, Beauty, Claudia and Emanuela for this great little video.
What is global health to you?
What should the Global Health Institute be?
What should the Global Health Institute do for students?
Hi, my name's Sean, and global health to me is international, interdisciplinary forces and ideas that come together to promote healthcare throughout the world.
Global health for me means considering health, its causes and its outcomes with an interdisciplinary approach, beyond a biomedical perspective, taking political, economic, social and cultural factors into account.
Hi, my name is Noelle.
Hi, my name is BT.
We think global health is a multidisciplinary field that celebrates the collaboration of different disciplines in trying to tackle different health problems around the world.
A collaboration that's not only one-sided, it's from the global north and the global south coming together to bring ideas in health treatment interventions.
I would like to see the King's Global Health Institute focusing on fostering partnerships between researchers, policymakers and the public. It would also be great to see the Institute involved in public engagement and getting students and alumni involved with this.
What I would like from the Global Health Institute is a space where people from every discipline in the university and outside the university can come together and work on projects and ideas.
Bring people together, first of all, and give everyone a chance to speak and give their contribution to global health as a field.
A lounge for all global health enthusiasts. We did talk about that.
I like that.
It's a good idea.
I like that a lot.
Where we can all go and drink coffee and talk about health problems. And we can have like people come from every discipline and just have a cafe lounge. And we can all sit down and talk.
Right. So I hope everyone got the main point behind that presentation, which is the Global Cafe. And I just wanted to raise this because those people that know me well know that I'm actually one of the UK's single largest importers of Ethiopian coffee, as well as its consumers. But seriously for a moment, although I think that is actually a great idea, I think there were 4 points that emerged from the students' videos that they put together. The first is that this institute needs to be about bringing people together. And frankly, that largely is what our institute is here for. It's to unite our 107 academic faculty working across over 20 departments in 5 faculties in health, arts and sciences to bring them together with our 250 undergraduate and postgraduate students and hopefully to engage an increasing number of even better trained PhD students through the doctoral training program that we want to start next year. The Global Health Institute is about interdisciplinarity. And global health is, or it really needs to be, fundamentally an interdisciplinary venture. So it is about health and it's about healthcare, but it's also about much, much more than that. If we want to close the health and treatment gaps that Chris was referring to between rich and poor nations and between the more and less advantaged within nation states and societies, we have to do better at understanding social determinants. And as our students emphasize, this means that we need to be working with policymakers, patients, and public. And cultural and health system understanding, behavioral and management science are absolutely crucial for effective implementation of healthcare strategies. And political science and economics fundamentally underpin effective knowledge translation into policy and practice, which is where we should all be at. So somehow we need to put the social back into health and healthcare. And I believe that this is an area where King's is exceptionally well placed to make a really strong contribution. So KGHI benefits from the recent strategic investments in the Faculty of Social Science and Public Policy. We've got a new School of Global Affairs, and that aligns new departments of global health and social medicine, international development, with the BRICS country institutes and geography. We've got a new policy institute, we've got a new business school, and this is allied to established strengths in politics and economics, including health economics, war studies, defence and security. So at KGHI, we're absolutely committed to achieving interdisciplinarity in everything we do in education, training and research. But we're committed to that not because it's something that we can do or it sounds good, but we feel that it's absolutely fundamentally necessary to making progress. And then we've got partnership. Partnership is, again, something that is essential. It's in the DNA of the global health discipline. You can't make progress without partnership. But I think that there's some important issues here that we need to be aware of and that we need to discuss a little bit in global health. So we've heard about the treatment gaps and the health gaps. 99% of maternal deaths happen in the poorer south of the planet. But we all know that healthcare resources to address these kinds of problems are concentrated in the north. There are enormous inequities, but the historical, social, political and economic reasons for those disparities also impact on our own academic and educational discipline. So there's nothing that's very fair about global health at the moment, because whilst most of the morbidity may be in the south, most of the global health institutes are currently in the north. And while there's not a monopoly of expertise, knowledge and skills, nevertheless it's the case that research capacity is much stronger at the moment than the north and the south. And funding and access to funds as well is disproportionately skewed. But in rebalancing things a little, I think we need to acknowledge and be clear that the really important knowledge and understanding about the local culture, about the nature of health systems, about local policy and what might be priorities within a particular country, this is knowledge that resides in the south, where that work is currently being carried out. So if we're looking at where innovation, true innovation, is likely to come from, and where solutions are to be found, we need to look to the south. We need to transfer knowledge and experience through a strong commitment to capacity building with our partners. But increasingly, as capacity builds, we need to move towards a much more fluid system of bilateral exchange of knowledge and ideas and know-how. And we need to anticipate very soon, I think, a transfer of power and a transfer of leadership as well in global health programs from the north to the south. Now, you may well ask in all of this, why a global health institute at King's now? And what has King's been doing all of these years? Obviously, this isn't the beginning of global health at King's, which as a discipline I think has been growing incrementally over at least the last 10 years. In the last 5 years, we've seen the foundation of 3 postgraduate master's levels programs in global health and social justice, in global mental health, and we've also seen the birth of undergraduate programs, integrated BSc in global health, the global health BA and BSc in global health and social medicine, and the international development BA as well. We actually have more than 200 students in this program, about 100 master's students and more than 100 undergraduate students at the moment, and many, as we found through the engagement, enthusiastic students on other programs. We've heard Chris talk very generously about the health partnerships, but I agree, these are unique. And the achievements in Sierra Leone were outstanding, but the achievements since 2003 in Somaliland, where whole medical schools and nursing schools where none existed have been founded and have become stable and independent with relatively little, but still important continuing support. And these, bringing the King's academics, the King's clinicians and volunteers from across the NHS into these partnerships to support these programs has been something I think really important that King's has done. But there's been strength in research as well. It's just that this research hasn't been traditional tropical medicine stuff. We've not been doing the MDGs, not much HIV, not too much TB, plenty of maternal and newborn child health. But look at the other areas where we've got the strengths: global surgery, as Chris was mentioning, global mental health, palliative care, aging research, cancer care. dental care. So these are all areas which are increasingly being recognised as being fundamentally important as we shift to the SDGs, and we acknowledge actually where even in the global south the majority of the morbidity and the mortality is actually occurring. And so if we can actually bring off the trick of combining these established research strengths with the interdisciplinary strengths in social sciences, in policy, in geography, in political economy and development studies, then I think we have something which is a real strength. But if we're talking about a problem or a limitation, when we started looking at this a year or two ago, it would be this. And yes, those are Mayan corn silos, as well as all of the others. And so when faced with siloed strengths in organisations, one temptation can be to take the hammer and the swinging ball to the silos and let's destroy this and completely reconstruct. And as any management guru would tell you, that's an absolutely fatal error. Because what it fails to recognise is the strengths that exist within those silos, the disciplinary strength and knowledge and expertise, the teamwork. And so that's not what you need to be doing, but you need to be interconnecting these groups so that they talk to each other and they work with each other in novel ways. But this is more about more than just making connections. It's about making functioning and flexible networks that exchange knowledge and skills and involve creative working. So the question is, what would be the glue that might unite all of these different elements and these different strengths that existed in King's before we launched the Institute? What would be the one thing that we want to be known for doing well and achieving it? Not the only thing that we want to do, but the one thing that we would want to be doing really well and really effectively. So I think the backdrop to this that we need to recognise and think about very briefly is, first of all, the focus on universal healthcare. So this is something now very strongly supported at the WHO. Dr. Tedros has said that of all of his priorities, this is the central priority that underpins everything. It's fundamentally about equity. It's universal access and coverage. And what does this mean? It means more than just everybody getting care. It means that all of the disorders and the conditions need to be addressed by the basic level health system. It means that all of those in need get the care that they require. And so if you do universal health coverage, then you do equity as well, and that's hugely important. So that's one area of focus. The other is the changing patterns of morbidity. So yes, there's demographic aging going on all around the world, more rapidly in the south than the north. There's a growing morbidity burden and mortality burden from chronic disease. And with this, we're seeing multi-morbidity, so we're seeing complexity. And health systems in the south, and indeed arguably in the north, are not well geared up and designed to actually manage continuing care. It's relevant for chronic disease conditions, but it's relevant for episodes like maternity care. You have your antenatal care, that's continuous, you have the delivery, you have the postnatal care, and it's even relevant for episodes of surgical care as well. So the light bulb moment came when we realised that all of us, whether we were working in palliative care, whether we were working in mental health, surgical care, were effectively bumping up against the same set of issues. We were trying to introduce innovations and guideline-based care, and we found that weaknesses and limitations within the health systems were preventing these innovations effectively taking root and flourishing as they needed to do. So perhaps we need to look at healthcare delivery, and we need to look at health system strengthening as remedies to this problem. And I'm just going to give a practical example very briefly of what I mean by this, which comes from our NIHR-funded Global Health Research Unit asset, which is about health system strengthening in sub-Saharan Africa. So in the first 9 months of the project, Lara Farrell, who we see in the picture on the top right, holding the Practical Approach to Care Kit guidelines, took the Practical Approach to Care Kit, which is a completely comprehensive, integrated set of guidelines for primary health care in South Africa, where 90% of consultations are nurse-led, and she worked with the Ethiopian Ministry of Health, together with the British Medical Journal, to so-called localise these guidelines. Incredibly complex bit of health system adaptation, cultural adaptation to the resources available, the regulations, and the cultural issues about the way in which care was delivered. And we finished that work, within 6 months, and the Ethiopian version of the PAC guidelines have been introduced. Great, you say, so another set of guidelines. What's really interesting about these guidelines is that they're organised along pathways of care, and it's completely integrated, so it actually doesn't address the disease that the patient might have when they come in, it just addresses the symptoms. So it might be a confused patient. What could cause that? Meningitis, depression, dementia, all kinds of things might be behind a confused patient. But the guideline takes you through from the symptoms through into the conditions. And there you have the other really radical thing about these guidelines, because it's taking the Ethiopian healthcare system into entirely uncharted territory. So all the bits outlined in red there, chronic respiratory disease, chronic disease of lifestyle, epilepsy, mental health, musculoskeletal disorders and palliative care, were not previously available through the primary healthcare system in Ethiopia. If you develop diabetes, you'd have to go to a tertiary hospital or a private doctor if you could possibly find one, and you may or may not get an oral hypoglycemic agent, let alone insulin. So now the Ethiopian government, as part of its program of universal health coverage, using PAC, is committed to scaling this up across the nation. I don't know if they realise just exactly what a difficult thing they're trying to do. So what we're trying to do in ASSET is working with the government, not to see whether PAC works, because it's an evidence-based guideline, so it should do, but what it actually takes in terms of health system strengthening in order to enable that guideline to be delivered with effect. So the ASSET programme is one of 3 NIHR and GCRF programmes to the value of £21 million, each from 2017 to 2021. It's a fantastic opportunity that the Institute has right at its very birth. ASSET is about health system strengthening across maternal care, surgical care and integrated primary health care in Ethiopia, Zimbabwe, Sierra Leone and South Africa. We've got the RH4C MENA, Research for Health in Conflict, led by Richard Sullivan and colleagues, which is a capacity building program, but it's basically about refugees and displaced people in the region, conflict affected. The problems in the refugee camps at the moment are chronic and continuing diseases and mental health. If you have cancer or need palliative care, what do you do? How do you deliver care under those really difficult and straitened circumstances? PRECISE is a really innovative program that, through large data collections of cohorts of pregnant women in 4 sub-Saharan African countries, is looking at the way that biomarkers can be combined with social indicators in order to understand placental disorders and their origins at the level at which you can actually intervene to improve detection, early treatment and prevention of the negative impacts of those placental disorders on maternal and infant outcomes. And all of these programs are complemented by Andy Shannon's amazing work on the cradle trials from 2010. We'll hear about this later, so I don't want to steal Tanya's thunder, but essentially a way that a really simple device can actually crack something that needs doing. So detecting the real killers as far as maternal mortality is concerned, which is pregnancy-related hypertension, septic and hemorrhagic shock, again in a way that interventions can be provided. So all of these programs, I think, represent some of the fundamental values and strategies that exist within our King's Global Health Institute. We're about practical, intensely practical and pragmatic, scalable solutions to improve the delivery, quality and outcome of healthcare. We're going to be working closely throughout with policymakers, ministries, providers and patients so that we can achieve real impact even during the duration of the projects. We're going to build interdisciplinarity in everything that we do, and we're going to be establishing pretty large research networks of partners and partner-to-partner interactions, and we'll have a real commitment to capacity building, not just a project-related capacity building, but a continuous stream of capacity building with a coherent strategy that new projects and programs can tap into. And of course, this is a platform on which to build. So come back here in a year, 4 years' time, it's 4 years for the programs, and hold my feet to the fire on these things, because these are commitments. This is what we want to be known for and known by.